Good morning, everybody. Welcome back to Journal Club today. Today we'll be discussing the real hot topic, which is the discharge trial, which has certainly generated a lot of discussion out there in the media. It's a great pleasure to welcome a friend and a colleague, Alessandro Sticchi from Humanitas Hospital in Milano. And once again, welcoming back Professor Colombo. Thank you, Prof, for joining us. It's a real pleasure, and we're looking forward to hearing your thoughts on this very important trial. So, Alessandro, please, if you could start.
Yes, good morning, everyone. It's a great pleasure to be here with you today, and also especially to have the founder of our JC program, Professor Colombo, here. The first question that we have when a new trial comes out is why this trial? So we have to consider that coronary artery disease is the leading cause of death in high-income countries, and not only in high-income countries, but also in low and middle-income countries. And around 40% of patients undergoing invasive coronary angiography in Europe and the US actually have coronary artery disease. And the invasive coronary angiography implicates some risks about death, myocardial infarction, and stroke. And so an effective tool, an effective diagnostic tool, non-invasive, a non-invasive one, could rule out coronary artery disease in the numbers of around 2 million annually with negative results. And coronary computed tomography is the favorite candidate for this position, like tool for its effectiveness and is spread on the territory and its cost effectiveness. So the other points that the authors highlighted in the protocol was that the invasive coronary angiography implicates considerable mental and physical stress in patients and a longer duration of hospitalization associated to the catheter-based examination. But in my mind, the question point was, but a double step is more stressful for the patients, and a modern way to perform PCI, like the hospital in routine practice and additional steps, could be less or more cost effective. So first of all, we have to look in the back in the literature, and we have several trials that investigates the computed tomography compared with functional physiological tests. And we can see that in all these really important big trials, we have the non-inferiority of the computed tomography in the same scenario of stable chest pain and intermediate pre-test probability. The characteristics of the discharge are really unique because it is a European multi-center prospective pragmatic randomized trial, and it involves 26 clinical centers, and it is an investigator initiated with the coordination of the University of Berlin, with the primary hypothesis to evaluate the superiority of CT over the invasive coronary angiography concerning the safety of the patients with stable chest pain and intermediate test probability.
Alessandro, what is the difference between a prospective randomized controlled trial and a prospective pragmatic?
Yes, Prof. This is really a good question. As you can see in the last line of the slide, the pragmatic trial is a trial that is important for the routine daily practice. And the characteristic is that they didn't calculated in the MACEs, in the events, the silent events, like that one periprocedural MI that depends on biomarkers, or the silent cerebral ischemia. So it is a trial that is pragmatic. So they really consider the reality and not only the protocols itself. And it was a European funded trial, so with the European resources. The secondary MACE, something that is interesting, Prof, is the major procedural complication. As you can see, I highlighted in bold that further complications prolonging hospitalization over the 24 hours are considered major procedural complications. So this is a point that we will see in the results that determines the advantage of CT. Because it is a pragmatic trial, also the eligibility criteria are very straightforward. So patient with chest pain with more than 30 years old, and they are evaluated for the chest pain with the CCS, the Canadian Cardiovascular Society Angina Grading Scale. And of course, they gave their consent. And about the grading of the screening, the pre-test screening, they used this calculator that was developed from a meta-analysis, an individual patient meta-analysis of around 7,000 patients. About the exclusion criteria, we have really few, and are hemodialysis, no sinus rhythm, and pregnancy. So they randomized 3,546 patients one-on-one to coronary CT angiography and invasive coronary or invasive coronary angiography. Of course, from the name itself of the trial, the patients with negative results were discharged, and the patient with positive results from both the methods undergoing a clinical evaluation from the R team for the management according to the ESC guidelines. What is interesting, I look a little bit in the appendix and the protocol, is that several patients with intermediate disease, around 50%, were discharged from the CT. And also patients with more than 50% of lesion, of diameter of lesion, of stenosis, were discharged if they were less than 10% ischemia. And to understand these, they had an additional step, an additional functional test, ischemia test. So the steps are more than 2 in the end. I will skip this part of the statistical analysis. I will just highlight that it is there was a modification in the protocol because to maintain the statistical power, they need to extend the follow-up. So it is modifying intention to treat population. About the characteristics of the population, so the patients were enrolled from 2015 to 2019. In the 26 centers, and the characteristics of the populations of the two populations are really very similar. There are no significant differences. As you can see, the median age is around 60, and we have a nice important presence of women in both the populations. And what is interesting is that in 1/3 of both the populations, a functional test was performed. About the results of the...
One point that I don't know why they didn't put in this table the pre-test probability in both populations.
Yeah. The pretest, was...
slide you showed there was so-called intermediate, but goes from 10 to 60%.
10 to 60% is a large... yeah.
So this is something to keep in mind.
And about...
Sorry, Alessandro, apologies for interrupting you. Prof, if we could kindly just ask you to move a little bit closer to the microphone. Some of the people can't quite hear the question, or perhaps Alessandro, you could repeat the question.
Yeah. I think that I can move... Oh, Prof, yeah.
I can move here.
Grazie, Prof. Thank you. Thank you.
no, it's not really a question, it's a pointing that in table 1 would have been nice to know the pre-test probability of both groups, because 10 to 60% is a relatively large range. And as you can see from the result, you will understand that this is overall is a relatively low risk group.
Yeah.
Because you will see from the result. Okay.
Yeah, and we can see also, Prof, that the median time of intervention was, of course, the places for performed CT are shorter. The time is shorter, 3 days to perform a CT from the time from enrollment to initial intervention, and 12 days for invasive coronary angiography. We can also see that invasive coronary angiography was performed as a first step also in the 20% of the patients with computed tomography. So there is a relevant part of patients that needed also to perform that first step, the angiography.
So it means that in 80% of the patient randomized to CT,
yeah,
no angiography was necessary.
Yeah.
So if in this group of CT you would have done angiography in everybody, you would have done 80% of useless angiography, which is a real, very low risk situation. In our practice here, the number of coronary angiograms which are completely negative are less than 80%.
Definitely, yeah.
So, to me, this trial is not really very real world type of population.
And I get in through this the procedural characteristics of both the invasive coronary angiography and the procedures after the angiography. And as you can see in the small group of patients that performed angiography after CT, there was an higher rates of fractional flow reserve used, and also imaging. So and also the PCI at the end was definitely higher than in the group with the first approach invasive angiography.
Yeah, was higher as a percentage, but
Yeah.
as a crude number is about the same.
Yeah, it's about
150, 180. So, of course, if you do more angiogram, the percentage is less.
Will be low. Yeah. About the primary outcome, as we say, the primary endpoint was major adverse cardiovascular event, and is a composite of major adverse cardiovascular events with non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. We had a percentage of 2.1 of events, a rate of 2.1 events for the CT, and 3.0 for invasive coronary angiography, with another ratio of 0.7 and non-statistically significant. So it was designed for a superiority trial. In the end, they reached a non-inferiority result.
So why the two curves separate after few months? These are the horizontal axis is months.
Yeah.
Do you understand? I mean,
for the invasive
my perception was that if you do invasive, you may have more procedural
events,
complications, etc., etc. But the acute...
There is a trend to an increase and the separation of the two curves also at the later follow-up.
Yeah, why?
You see that the two curves are almost the same within the first 3 months, and then they...
So, why?
Yeah, this is interesting, Prof. And we can see also in each one of the events the measure procedural complication, as we see, were 0.5 for the CT and 1.9 for the invasive coronary angiography, and this was statistically significant as a reduction in favor of the CT.
But let's see after the procedure. Can you go back?
Sorry, which element did they include inside of this Kaplan-Meier? So the bleeding events were included.
Non-fatal myocardial infarction, non-fatal stroke, and cardiovascular death. Only
I don't know how to explain.
these in the primary endpoint.
Maybe the group of invasive coronary angiography, they repeated more the revascularization. They did like a step revascularization, and during the second events of the revascularization, they have like a very procedural myocardial infarction, so they accounted for these major events recorded during the follow-up.
Moreover, Prof, there were no differences.
But if you go back to
in the
prior
groups,
slide,
Prof, here you can see one by one the several subgroups of the composite MACEs.
Yeah, but everything seems to.
So for the cardiovascular death, for the non-fatal stroke, for the myocardial infarction, the cumulative incidence curve for the secondary expanded the MACE, so the composite of cardiovascular death, non-fatal MI, non-fatal stroke.
There is a p-value between the two curves or not?
No, Prof, there is the confidence interval, as you can see in the hazard ratio here.
So basically they are the same.
Yeah, they are the same.
Yeah,
they are the same.
It's just the noise.
If you see the scale in which the upper limit is 10%.
Only when we consider the major procedure related complications, we have a statistical significant difference.
Yeah. But you know, basically, this is a relatively low risk population. So, sorry to discuss before the end, but I think it makes more
sense.
alive. To take a low risk population and in 2022 subject this population to coronary angiography makes no sense nowadays.
Yeah.
Because you will have some kind of complications, relatively minor, but you will have some complications.
And your suggestion, Prof, is supported by the really impressive low rate of events if we compare the results of this trial as adverse events with the previous trials.
Yeah.
Like, for example, the Scott Hart, that was the rate 4.6%.
Yeah, but the other trials are a comparison with non-invasive testing. Could be nuclear, could be exercise echo, whatever, which is okay. But to do a prospective study in a relatively low risk population compared with an invasive testing, to me, I would not do the trial. If I am a patient, I would not take part in this trial, unless I am a high-risk patient. If I have diabetes, hypertension, typical chest pain, it's okay. Yeah. But otherwise, why to undergo coronary angiography if you have a low-risk patient?
What is interesting, Prof, about the procedural?
Yes. The baseline characteristics, if you see carefully, only 20% of patients had the typical chest pain.
Yeah.
In most of the cases, the chest pain was totally atypical. Yeah. And so that's these people were underwent like a coronary angiography without apparently any reason.
No, I mean, you do this 20 years ago, but not now. Come on. I mean, it's almost against the guidelines to take someone to go to coronary angiography. Okay, sorry.
And as you can see, Prof, the complications, they were higher in the first period, as you suggested before, and as after in the months, the following months, they were similar, and most of them are related to complication that extending the hospitalization over the 24 hours.
Yeah. And do we know the coronary angiography, how many were radial versus femoral?
Yes, Prof. It was in the, no, it's in another table at the end. But the 80% was radial, and around the 20% was femoral or other access.
Sorry,
yeah.
But it's good that we interrupt, at least we discuss
totally.
a little bit. Okay.
So about the main result, is really interesting to look at the difference, we say, Prof, with the previous trials, and because in the Promise and in the Scott-Hart, differently from the other trials that we see, there were they performed also the invasive coronary angiography. So they in the table with all the trials that I showed before, these one are the trials that are closer to this one in some way, and the results are similar, but yes, the events are definitely higher. So we could conclude that yes, the strengths are several. This is a multi-center pragmatic design. The adherence to the assignment of randomization was really high, more than 95%. The completeness of the trial at 3.5 years was 98.9%. And we have an important presence of women in both the groups. But yes, we have several limitations because the assignment randomization was open, not blinded. So the patients and the referrals knew the assignment. The incidence of diagnostic CT and the previous trials approximate 6%. We don't have an analysis of cost effectiveness. In this trial there were not CT-FFR or perfusion CT, and as Antonio said, more than 1/3 of patients had non-angina chest pain, and just 25% of patients in each study arm had obstructive coronary disease, suggesting that they might have considered a low risk, as you say, Prof, a low risk population for obstructive coronary artery disease, and not really an intermediate risk. This is just a summary.
Great. Okay. So thank you, Alessandro, for the presentation and initial discussions. Prof, if we could please just take some questions from the audience that people are asking, and Alessandro, please, as well. So some questions about the actual trial. So specifically, Aisha would like to know, number one, could you interpret this as a non-inferior trial, or rather is it better to say it's a neutral trial given the study design? And what does it mean, the word pragmatic in this case? What renders this trial as pragmatic? What do the authors mean by that?
Well, I think this trial, to me, the conclusion is a superiority, because according to the events, I would not do invasive intervention in this population. So I think the result confirm that in a relatively low risk population, CT angiography is superior to invasive. Pragmatic, I need to do some studies because personally I don't understand what is the meaning of pragmatic. So I'm going to go to the internet and try to understand, because to me it's not clear yet. So I cannot answer the second question. But to me, the trial has several limitations, because the main limitation is the population is a low-risk population.
Okay, thank you. And then there's some questions with regards to functional testing. So first of all, as you were saying, Prof, in 2022, maybe this might not have been a trial to be done, but what about incorporating FFRCT into this workflow, and how would that be utilized, let's say, in contemporary practice?
I think ideally FFRCT should be incorporated, but in real life, I mean, in Italy, I know only one institution where they do FFRCT. And we are talking about several million people country. So I think FFRCT is still a tool for research, but is not inside daily practice. So it could be incorporated, but we are far away from that point.
Okay. And then a question about the actual PCI that was performed in this cohort. I know, for example, in prior studies, there's been a criticism that, PCI was only performed in 10%, imaging was only performed in 10% of cases, for example. What was the quote unquote quality of the PCI here, Sticchi? Do they say how many times physiology was used, how many times intravascular imaging was used?
But I think the quality was the average quality. In the real world, IVUS is used less than 10%. So I think we always tell that you should use more, but you cannot go against reality. So I think the PCI was standard PCI, was not
even less in this trial, because the lesions were very simple, the population was a very low risk population, so they used like FFR in 10%, OCT 0.8%, and IVUS less than 10%. So imaging was very underutilized because maybe the lesions were very simple.
And several intermediate lesions from CT were discharged. So.
But I think the message is if you have a low risk population, you do the CT. If the CT is negative or slightly positive, finished. If the CT has something, then you can do invasive. That's what we do in real life. If you have how many times we have a critical lesion if the CT tells you that is 50%. If the CT tells you that is 50%, 90% of the time the lesion is non-critical.
It depends on the symptoms and on the patient's symptoms, always from. Because if you do like CT scan just for screening and you have 40-50% of the patient is asymptomatic, there's no evidence to do a coronary.
Unfortunately, Arif, we have to go because we have people pressing on the door.
Okay. No, I think we've just come up to time, so I think it's perfect time to end as well. So from all of us here at Journal Club, a big thank you, Prof, for joining.
Some work that we need to do, please go to the internet and try to understand what pragmatic means.
Okay, great.
Through Twitter, whatever. If we understand very well pragmatic, we'll circulate a paragraph to tell us what pragmatic means.
Thank you.
Okay, we'll put that on the social media. Okay. Thank you, everybody, for joining. I hope you enjoyed that session. Sticchi, thank you for the presentation, and look forward to all of you next week. Thank you.